This is the Emergency Medical Minute, sponsored by Mile High Ambulance.
So we'll do a quick med minute on something I've seen a couple of times in the last few weeks. And so obviously that means I'm looking for my third. So if anyone sees it, let me know. But we'll talk about Pneumomediastinum. We can kind of infer from the name that Pneumomediastinum just means air inside the mediastinum. So the mediastinum structure is sort of everything between the two pleural cavities, behind the breastbone, and then all the way back to the thoracic spine. It actually includes the thoracic spine. The structures inside the pneumomediastinum include things like the heart, all the great vessels of the heart, some smaller vessels, some lymph nodes, some nerves are in there. So a bunch of important structures sit in there. But there are two air-filled structures that pass through the mediastinum, and that's the esophagus and the trachea. And we can kind of split pneumomediastinum into two categories. One is kind of traumatic, and we'll talk about what that means, and then non-traumatic. And we kind of split them into things that we really care about, things that are important and probably are going to need some surgical management, and then kind of like the nothing burger patients that we sort of sit and watch, and hopefully they improve kind of with minimal management. And so for traumatic, it can kind of be the main thing that we would worry about would be like a stab wound, right? Like a stab wound to the trachea, and then air is going to escape from there into the mediastinum and kind of fill that up. There are other forms of trauma that can also cause it. So Boerhaave's is a perforation in the esophagus. Typically comes from something like an endoscopy where you're putting a camera down and you sort of get too close to the wall of the esophagus and you can either perforate it or weaken it. And that's a problem because we put a lot of food into the esophagus. And so you can get not only the air that escapes, but then food particles and things with bacteria on it. So that's a big deal. The other thing that I've seen happen once in my residency, it wasn't my case, but we had a patient that was getting intubated using a bougie, and the intubator was using a little bit too much force with the bougie and actually ended up perforating the trachea with the bougie. And we'll come back to why that one's kind of unique and important in a second. One of the cases I saw early on a couple weeks ago was a woman who had a history of bulimia, and so she had a bunch of strictures in her esophagus from that. And she had been recovered, she was a mom now, she kind of like lived a full life, but she had to have several dilations recently because of these strictures, because she was starting to have problems passing food. And she ended up getting a GI bug at some point, so was doing a bunch of forceful vomiting against some of these strictures that had been recently dilated, and she ended up perforating her esophagus that way. So those are things that are probably going to require some repair. The non-traumatic side of things tends to be things like really forceful inhalations against some sort of blockage. And so the most common one I think we think about, well, two of them, drug use. So something that's inhaled. So you have like crack cocaine or methamphetamine, something that you're inhaling, really trying to inhale really deeply. And that can cause these little micro perforations in the trachea and sort of let some gas leak out through those. There's not going to be a physical hole. If you were going to go look for one, you're probably not going to find a physical hole most of the time. You can get it from bad asthma. So I typically see that in kids. I feel like this is like really common. You'll find a little bit of pneumomediastinum on their chest x-ray. And that's just because they have this exacerbation going on and they're trying to take these really big deep breaths. I think we see it in kids a lot because their airways are a little bit smaller and there's worse asthma exacerbations, but that's one way you can see it. The most recent one I had was this guy who ended up having a pneumomediastinum with an asthma exacerbation. He was 30, so a little bit older than I'm used to seeing that. And then the last atraumatic one is a gas-forming bacteria that actually gets into the pneumomediastinum and starts creating gas kind of in there. And obviously, if you looked, you wouldn't find a hole most of the time. The trachea perforation with the bougie, the reason that one was kind of unique is because once the patient was successfully intubated, we didn't know that this had happened. And so the patient then got put on positive pressure, and pushing positive pressure through that hole, you're going to end up sort of blowing up the mediastinum like a balloon. And the mediastinum has kind of like all these walls on it, but it doesn't really have a lid. And so that air started tracking up and kind of created all of this subcutaneous air that was tracking all the way up to his face, which was really impressive on physical exam. And then you can actually end up with something called a tension pneumomediastinum, where all that air is starting to take up space that's normally meant for the heart. The mediastinum is in a very compliant cavity. That air starts taking up a bunch of space, and it can actually compromise the patient's blood flow. There's a theoretical procedure where if it was really, really bad, you could actually make a small nick or incision or use a needle to drain some of that air from just below the xiphoid, almost like you would with a pericardial effusion. I think in this case, one thing that we had going in the patient's favor was that the perforation had happened above the carina, because that's kind of where the bougie gets hung up in an intubation. And so they were able to actually right mainstem the tube, once they kind of figured out what had happened, right mainstem the tube, just keep the patient ventilated that way, and then take them for CT surgery to do the repair. So helpful thoughts on that one. Positive pressure is the thing that would cause this to become like a more emergent issue. And one thing to keep in mind, we don't use positive pressure for bronchs. So if someone has a pneumomediastinum and they need to be bronched, or they want to bronch to see if there's a hole that they can actually find, that is an option. But if we're worried this is coming from the esophagus, you use positive pressure in order to do an endoscopy, and so that's not an option. If there's concern for Boerhaave's, you can't take this person for endoscopy.
We'd like to thank our sponsor, Health One Continental Division, and Swedish Medical Center for their financial contributions to the EMM. Donations from them and listeners like you make it possible for us to fulfill our mission of producing and spreading free medical education to the masses. If you enjoy our show, please consider making a one-time or recurring donation to help cover our operational costs and keep the EMM awesome. Click on the link in our show notes to make a donation. Thank you for listening.